Good morning, my name is Francesco Maura from University of Miami, and I'm here attending American Society of Hematology 2024 annual meeting in San Diego. And this year, our group, in collaboration with the Moffitt Cancer Center, Memorial Sloan Kettering, and University of Calgary, is presenting an important abstract showing how whole genome sequencing can predict patients that will fail or will have a great outcome after CAR-T anti-BCMA therapy. So for people that are not confident with the concept of whole genome sequencing is a technology that allows us to basically decode the entire DNA that makes us the person we are. And so we can use that to compare a normal cells in our body with our code with the tumor and see what is the differences between the two. Myeloma is a tumor with a lot of differences. It's a very complex, and what we found is several genomic patterns, which are these alterations that makes the tumor different, the DNA of the tumor different from the normal, that associates with poor outcome or refractoriness after anti-BCMA CAR-T. Interestingly, some of these alterations can actually be targeted by other therapies, so they are specific to anti-BCMA, but might not be affected other therapies or other targets. That suggests that genomic-driven therapy, which means a patient gets the whole genome sequencing information before getting CAR-T or immunotherapy, could guide our decision in an area where we don't have one single drug, but we have multiple drugs, different CAR-T, different targets, and clinicians struggle right now to decide which drug we should give to which patient. So I think that is a first step toward a more individualized strategies for patients, where patients get the right therapy without wasting money, toxicity, and time. Among the genomic findings, genomic alterations that we found, there are definitely two main groups. One is the genomic complexity, alterations like T53, 1q gain. All these alterations that we know are bad for myeloma are bad also for immunotherapy. That creates definitely a need for this group of patients to understand why these patients are so aggressive even in the context of immunotherapy. What we think is that because they have genomic instability, they can lose easily other piece of chromosome or other alteration and piece of DNA. And this piece of DNA involves a pattern that makes the plasma cell less plasma cell. So BCMA is a protein that makes plasma cells. It's essential for plasma cell differentiation. So without BCMA, plasma cells struggle to be a plasma cell. That's why very few patients lose BCMA after CAR-T. It's always there. So when we target BCMA, if some patients have a less plasma cell profile because they alter their genomic DNA, then this patient will respond less to CAR-T, like strategies how to eventually upregulate BCMA, or maybe understanding which other protein this patient express might allow us to improve our strategy and maybe identify new target for these patients.